is presently available for almost all the drugs. The only problem which is there is the cost, as well as we are building upon the library. Because this is the library of mutations. So how it corresponds to the phenotypic resistance is what is to be seen.
Okay, so I'll just try and wind up in the next 1 minute or so. So these are the 3 new tests which are there, but they need to be done only in patients who have a detected INH or isoniazid resistance. Don't do these tests otherwise. Okay, so you have a expert XDR, which is possibly going to be incorporated into the program, and that is going to be the first follow-on test. Ma'am has already talked about the drugs which can be tested. Then Dr. Varinder already has talked about the line probe assay. I will not repeat this information again. There is something known as line probe assay for pyrazinamide, which is being developed by a Japanese company. At the moment, we don't have an access to it in the country. It might be available. Then we have talked about an NGS, or the next generation sequencing. It is available. It can be done on respiratory samples. Ma'am has already talked about the limitations as of now. The database is building up, and sometimes the results are not correlated with the genotypic or the phenotypic DST, and hence we are still not recommending this to be done upfront. We have more data and the experts look at that. WGS possibly don't do it at the moment. Okay, so this child has rifampicin resistance. This is what we found. So I think so. We'll have a last word from Dr. Varinder on something which we want to talk about, which is that you have a patient where you don't get microbiological results so often which are positive, but the sensitivity and specificity of GeneXpert is shown to be like 70-80%. So what does it mean? So some key messages from you, sir, regarding how do we sort out this problem?
So one of the things which is important to remember is that all the nucleic acid amplification tests have been tested against a gold standard of culture, not of a clinical reference. So when we say it is 70%, 80%, 90% as sensitive, it may only means for culture positive, while our culture positive is about 40-50%. That means a NAT is a very good rule-in test if it comes positive, but it is a very poor rule-out test. That you can have TB with a normal NAT. Remember that. A negative NAT does not rule out TB always. That's an important thing. One slight correction, you asked me about LAMP, I got confused at that time. LAMP has lesser sensitivity than expert, not same.
Okay, so thank you very much. So that is the key strategic shift in pediatric TB diagnosis. We are moving from clinical definitions to confirmed diagnosis. The rapid diagnostic test, especially the expert, has been the game changer. Upfront use of CBNAT has made this a reality. Try and achieve universal DST, do proper sampling, and look for microbiology, and newer tests would improve diagnostics and DST. Thank you very much, and sincere apologies for crossing the time. Thank you.